and gentlemen, good afternoon. And as first, I would like to thank you, Gigi, and particularly Olivier Ada, for the kind invitation. It's a pleasure for me and from the team of Monzino to be here. So, regarding the topic of challenging patients in terms of rhythm, we know that the role of the heart rate value and of the rhythm is very pivotal in determining the image quality and the diagnostic performance of CT. We have two settings to cover, so the higher rate alone. Why alone? Because sometimes the higher rate could coexist with the higher heart rate variability, and that's the worst setting for cardiac CT that correspond to the atrial fibrillation patients. So we start with the high heart rate setting. We know that the ideal scenario for cardiac CT is that of patients with stable and low heart rate, less than 60-65 BPM. Conversely, when the heart rate increased to 70, 80 or more BPM, 100 or more, two types of artifacts can affect the image quality: the slice misalignment, the stir trap artifacts that are typical of the scanner, of the 64 slice scanner with a 4 centimeter coverage, and the motion blurring that commonly characterize particularly the right coronary artery, and then is typical in high heart rate patients. So in the setting on the very high heart rate, more than 80 BPM, the available literature is very limited. This is one of the only paper I found in the literature, performed with a recent second generation of dual source CT, a study dedicated to a small sample size, 33 patients in the setting of heart rate more than 80. The authors obtained a good image quality, good assessment in this setting, but with the relevant drawback of the radiation. The effective dose was more than 20 millisievert. So what we can do with the scanner we have in Monzino, as Olivier told, starting 2015, the Revolution CT, the scanner combines fast gantry rotation time with a 16 centimeter Z-axis coverage, and the snapshot freeze, the tool, the software tool to address the challenge of coronary motion blurring and to solve the most part of residual motion artifacts. So it's important to underline that snapshot freeze per se, so without the latest scanner generation with a 64 slice CT, as documented in this paper, was able to improve the diagnostic accuracy of CT in the setting of moderate to high heart rate, 70 BPM. Just an example, you can see here a big motion artifacts in the LID that not allows the evaluation, well corrected by the snapshot freeze that identified this lesion that was confirmed by the invasive assessment. And again, the snapshot freeze without revolution, but with a 64 slice, was documented as a useful tool to address the motion artifacts in the Victory trial, a prospective multi-center international trial dedicated to more than 200 patients with clinically indicated invasive coronary angiography. The paper is now in press. We documented that the rate of CT scan free from motion artifacts was improved from 65 to 79% by the use of snapshot freeze due to a systematic improvement of image quality score independently from the different coronaries. And in summary, in the setting of 64 slice CT, snapshot freeze allows to improve the diagnostic accuracy of the method in the vessel, in the atrioventricular groove, so the circ and the right, and the diagnostic accuracy by snapshot freeze was improved primarily in patients with higher heart rate, more than 70, and severe stenosis, more than 70%. But coming back to the Revolution CT, so this paper from our group, recently accepted, evaluated 200 patients with a clinical indication for CT. 100 patients, we selected 100 patients with more than 80 BPM, so extremely high heart rate, comparing with a standard patient with less than 65. Here are the data. The heart rate during the scan was significantly different, 57 versus 93 BPM. The dose was very interesting. We have 1 millisievert in the low heart rate group and a good value of 2.9 in patients with more than 80 BPM. Good data, particularly comparing with the previous literature. The role of snapshot freeze in this setting, also with Revolution TT, is important, particularly in patients with extremely high heart rate, allowing to solve more than 50% of residual motion artifacts, and accordingly, the image quality assessed by a Likert scale, by a qualitative fashion, was identical in the two groups, with same distribution of artifacts and with no differences of the diagnostic accuracy assessed in a retrospective fashion in comparison with CAT when patient underwent to the invasive modality after CT. Just a clinical case, a man with risk factor symptomatic for atypical angina. The pretest likelihood of coronary artery disease was good for CT, was intermediate, 59%. He already underwent an exercise EKG that was suspected for ischemia. So patient presented with 125 BPM at our attention. We treated with intravenously beta blockers obtaining not more than 100, and then we scan at 102 BPM. But apart these values, we have a good image quality with detection of this severe lesion in the ostium of LAD that was confirmed by the invasive assessment. You can see here the data, and treated by PCI. Another example, 105 BPM, good depiction of all coronary artery free from motion and a rule out of significant stenosis. And finally, an head-to-head comparison between low, 51, and high heart rate in the right coronary artery, that is the coronaries commonly most affected by the motion artifacts. We can see here a very good image quality across the whole path of the right without motion. And finally, the coexistence of two worse situations for cardiac CT, the stents and the high heart rate 80 BPM. So also in this case, we have very good image quality with detection of these two, ISR confirmed by the invasive assessment and then treated. So the summary for our experience in high heart rate is we still recommend the use of medication of beta blockade, not for image quality, but particularly to reduce the dose and also to save time for the post-processing. But we can go to the scan in all cases by using a large acquisition window, by using the snapshot freeze that allows to solve the most of residual motion artifacts with a mean good image quality, excellent sensitivity, and particularly low radiation exposure. But we pass to the second topic of this presentation, so the worst situation for cardiac CT atrial fibrillation patients in whom coexist both high heart rate and high heart rate variability. So what we have in the literature, in this review published in Radiology recently, we can underline that the small data we have with small sample size of the study, 12, 19 patients, selected patients in terms of heart rate, very low heart rate, and the image quality that is strictly dependent from the heart rate during the scan. Regarding the dose, we have more than 10 millisievert in all studies, with the exception of 9, with dual source CT, and interestingly, the most of these studies was performed not with a first generation scanner, but with at least dual source or 320 row scanner. The diagnostic accuracy in AF in these studies was not bad, more than 80%, but as underlined by the authors of this review, with two drawbacks. So the significant higher radiation exposure due to the variation of heart rate and the need of a very large acquisition window, and the lower prevalence of significant coronary artery disease, less than 30%, that is ascribed to the retrospective nature of the most of these studies. So with Revolution, apart from the other features I showed for the high heart rate, we have a dedicated tool for the arrhythmia management that allows to handle this type of patients with irregular heart rate. Particularly, the software allows to monitor the heart rate and to avoid to scan in the presence of a short RR interval and to go when the wide diastole is available. So the first question we have when we started with the program in atrial fibrillation 2015 was we need a single data set to analyze, or we need due to the worst situation, a second data set. So a double acquisition. The study that we presented last year at TCR is now submitted for the publication. 50 and 50 patients randomized in one and single and double acquisition. Same heart rate during the scan. The dose is obviously the double for the group of double acquisition. And interestingly, the interpretability by segment analysis was the same in the two groups with the same image quality score. Here an example of two data sets acquired with wide acquisition window with this type of DLP, good image quality. And another example with even worse situation, AF with very high heart rate, single acquisition, the half of DLP, and again, a good depiction of coronary artery disease. So the first answer is only one data set for acquisition is enough. The second point, we have a significant impact of heart rate on the image quality. This a good paper from Ernesto Di Cesare, performed with a 64-slide CT, suggests a good image quality with this latest scanner generation until an heart rate of 72. For this reason, in this large group of AF patients, this paper is accepted a few days ago in European Radiology, we divided our population on the basis of the heart rate value with a threshold of 75 in order to evaluate if for more than 75 we have still good image quality. You can see here 66 in less than 75 and 94 in more than 75. The dose is exactly the same, 3.8, so very good. In this setting, the role of snapshot freeze is probably more impressive than in low heart rate variability but high heart rate, because also in the group of heart rate less than 75, the impact of correction of the residual motion artifacts is high with this tool. And thanks to the combination between hardware and software solution, we have the same image quality in the two groups, less or more than 75 BPM. Just an example of less than 75, low AF but low heart rate, good LID, severe circ and occlusion of right, and more than 75, 130 BPM with good rule out of significant disease. The last topic is the diagnostic accuracy. This paper was recently published in Radiology, 83 patients versus 83 in atrial fibrillation, scheduled for CAT. We found the same image quality between the two groups, sinus rhythm and AF. Different, obviously, heart rate during imaging. Different dose was 1.3 in sinus rhythm and less than 4, that is still good in atrial fibrillation. But the most interesting data, the accuracy is very high, and is exactly the same between sinus and AF patients in segment, vessel, and patient-based analysis. Another example, rapid AF with good rule out of significant disease, and conversely, in this other case, during AF, detection of moderate stenosis in LAD confirmed, and then severe lesion in circ, again confirmed by invasive assessment. So the final case, again, the coexistence of stent and atrial fibrillation in this anomalous circ from the right, the detection of this significant ISR of stent confirmed and again treated by the invasive procedure. So our summary for atrial fibrillation is that the use of medication, of beta blocker therapies, seems less useful than sinus rhythm, so less reproducible response of the patients. A single data set, so a single shot, a single acquisition seems enough for having good image quality, but we need in all patients, also with less than 75 BPM, 500 milliseconds as a wide acquisition windows that allows to evaluate the systole, the end systole until the whole diastole. Snapshot freeze is very useful in this setting, and we have an average of more than good image quality with excellent accuracy, and the dose is very good, is less than 4 millisievert in all cases we done with this type of scanner. I thank you very much for your kind attention.
Many thanks, Daniele, for this impressive presentation and all the results that you published recently to show the benefits of Revolution CT in your clinical practice. Actually, based on your presentation, it seems that today atrial fibrillation and high heart rate is not anymore a challenge for you in your clinical practice. Do you think there is a link between this capability and the fact that you increase your activity in Monzino?
Yes, absolutely. So due to the ability to scan, so we can tell all patients. So we expand with the same population, the 20% of activity in terms of numbers, without increasing the slots for cardiac CT. So the 20% correspond to the patients that arrived with the previous scanner to our lab, and in which we can do the cardiac CT for very, very high heart rate or atrial fibrillation. But obviously, we have other advantages that you already underlined in terms of safety, particularly the amount of contrast, and the dose that was reduced, as you told, with an average of at least 50 to 70%.
Maybe one last question. What do you think are the remaining challenges in cardiac CT for you?
So I think, so that's a very good question. So still challenging for the anatomy is for sure the presence of a structure that lead to beam hardening artifacts. So related to the limited spatial resolution along the Z plane. And obviously I'm meaning to stents, particularly small stents, but particularly to the calcium. So they are still challenging for the anatomy, but fortunately, but this is the topic of Gianluca's presentation, we have tool to overcome this limitation, going to the functionality of the lesion and not only to the anatomy.
Thank you. Thank you very much, Daniele.
You're welcome.